part, it can be examined and it can be evaluated and it can be assessed by ultrasound. Going to the final thing, which is the large intestine. First part is the cecum, and then the colon, which is ascending, transfer, descending, sigmoid, rectum, and the last and very important part, which is appendix. This is the several parts of examination. We have to assess it, we have to evaluate it. When the exam is bowel ultrasound, this part should be included. Your exam, it should be included, each segment, to say it's normal or say it's abnormal. Except pyloric stenosis, it's a separate examination, needs different preparation, needs a different dynamic examination. So how it's look by ultrasound? By ultrasound, the small intestine, it's look like a fluid-filled loop, as we can see here. The large, it's contained of the dirty shadow because of the gas. And this is the pyloric valve. It's look like a tunnel. It has a length, it has a width. This is the what you are seeing here. The green arrow is the stomach with the content inside, and the small bowel, as you can see here, it's a loop, fluid-filled loop. And this is the tunnel, or this is the valve. It should be evaluated. You see there is a length and there is thickness. This is the ileocecal valve. It's just an opening. It's different from the pyloric. It doesn't have a thickness. It doesn't have a length. As you can see here, this is the cecum, the first part of the large bowel, and you can see the dirty shadow inside it. And this is the loop, the fluid football, which is the ileum, the last segment of the small intestine. And you can better evaluate it in a sagittal view. So you have your normal anatomy. So the normal anatomy, it's very important to have an easy access to your examination part. This is our tool, our first step for sonographer. Know your anatomy very well. Just to be specific, to put your probe where it's interested. After you have known your anatomy very well, know how it's look like by ultrasound, to better evaluate it, to recognize it easily. After that, you have to collect data. You have to collect information to provide a positive case or a negative case. You will receive a request asking for a disease. Is it in or is it out? So you have to have a proper information, proper data. You are the one, you are gathering it and give it to the doctor to have a proper diagnosis. If the doctor have a proper diagnosis, that means you are a good sonographer because you are giving them the proper information. So to say it's a healthy bowel examination, what is your checklist? While you are scanning, you have to provide and you have to look for all information you needed to prove it. And while you are scanning, you look for it. For a healthy bowel, the first thing, you should have a normal location. For a central, the small bowel, and the large bowel will be a peripheral. While you are scanning, you are making sure it's not displaced by mass, by tumor, by abscess, by collection. You are excluding everything while you are scanning and make sure that the small bowel is in the center of the body and the large bowel in the periphery of the body. Compressibility, the bowel, it have this viability, is easy to compress. By the probe, you can evaluate the bowel, is it compressible or it's not. This is a sign of a normal, healthy bowel. Peristalsis movement, as you know, we all know that the bowel have a normal movement. The movement, it should be not too fast and not absent. It's not working. As you can see here, you will hold your scanning and you will observe. Is it absent or it's too active? This is, as you can see here, it's not, there is no movement. It's absent. Though this is a pathology. This is not normal. And if we have it so active, also see how it's the content, it's so active and there is free fluid around it and there is so much active in the bowel. This is also abnormal. The normal peristalsis movement, it should be in the normal range, not too fast and not an absent. This is the normal sign of a healthy bowel. The last, before, it's the echogenicity. The bowel have an echogenicity represented by what? By the bowel layers. Bowel layers, it's represented by this sign. We call it gut signature. If you have this sign, you have a normal bowel. You have to look for this sign. This gut signature is represented by what? By 5 layers of the bowel. The bowel have 5 layers. Each layer has a different echogenicity, and we can see it and we can recognize it. For the first layer is a superficial mucosa. It's a fine bright line. Second layer, deep mucosa, which is a gray. Third layer is submucosa. It will be bright. And muscularis, dark, finishing with serosa, it's a bright line. So it will start from bright line, ending with what? A bright line, to collect all the 5 layers. So when we have to measure the thickness, you have to measure from fine bright line to fine bright line. Do not measure the whole diameter of the loop. This will give you wrong information. It should be from the, if we zoom this one into, you can see it, these 5 layers. Mucosa, deep mucosa, submucosa, muscularis, and serosa, from bright line to bright line. These 5 layers it should be. So we have to measure it from here to here, and from here to here. Do not measure the whole diameter of the bowel. To provide you a good thickness. Good thickness provide a good information for a health bowel. Final thing, to say it's a normal bowel, it's the content of the bowel itself. Is it fluid filled in the small bowel, or it's a gas or stool within the cecum or the colon? You want to make sure there is no masses, there is no tumor, there is no abscess within it, there is no pathology inside the bowel. If it is fluid and if it is gas, so it is a normal bowel. So you get your tools, you get your information. You know the normal location of your bowel. You know the normal appearance of the bowel. You know what should you look to convince the radiologist that you have a normal, healthy bowel. So you are ready to do what? You are ready for a technique, for your scanning. So you have everything. Now you know where you're placing the probe and how to provide information. Once you're starting the technique, I will explain to you our protocol. Each hospital has its protocol. For me, the protocol is very important. The protocol, what is it, a protocol? It's a sequence of image. It's usually written by the radiologist and signed by the radiologist. That to make sure you are covering the whole area it's needed to be covered. That you are providing the whole information it's needed to provide. And easy for the second study for a comparison. So the protocol, we should memorize it, and we should follow it, and we should take every sequence of the image. No need for preparation. Bowel, no need any preparation for the patient. And the position of the patient, it should be in the supine position. We start our examination with the curve probe. Why we start with the curve? It's a superficial organ, it's a pediatric. I'm starting my exam with the curve probe. Why? Because I need a bigger field of view. I need more penetration. Because I want to have a look for the whole bowel. I want to make sure it's in normal location. There is no deep masses displaying the bowel. There is no collection behind it. I want to see, is it the peristalsis movement good? If there is any intussusception. So I will start my examination with the curve probe for a bigger picture or bigger field of view. I will document this with the 6 image. 6 image, I divide the whole abdomen into upper, lower, 3 upper, 3 lower, right, mid, and left. This will make sure that you are exam each segment of the bowel, large and small. For example, for right lower quadrant, what you will examine? Appendix, ileocecal valve, part of the cecum. So you will cover what? You cover a small bowel, one of the valve, and the large bowel, etc. In each part of this you are going to cover it, and you will document it, prove it that to the radiologist that you covered this area and you examined this area. After the curve linear probe, we'll go through the linear because you need now more information. specific information. You need to see the 5 layers. You need to see the thickness. You need to see the content exactly. Is it fluid or it is just blood? Sometimes the blood is fluid with the echogenicity, with the septation, and you can see it by what? By a linear probe. By a linear probe, you are performing mowing the lawn maneuver. What is it, mowing the lawn maneuver? It's a survey that you can start, from the large bowel, going the whole quadrant, upper, lower, and left and right, and then going inside central with like a zigzag maneuver. By applying what? By applying graded compression. Do not compress force at one time. You have to be gentle. This is the body and this is the probe. Play graded maneuver with a little undulation and sewing. Sewing, looking for the bowel, displacing any gas, looking for the small, for the large bowel, examine each segment of the bowel. This is the maneuver that you have to apply it by a linear to examine the bowel. Also, by documented this to the radiologist with this 6 images. So 6 per curve and 6 per linear, so this is what? 12 images, if it is normal. If it's, of course, abnormal, we have to take more images. While you are examining, you have to label 3 anatomy, appendix, which is very important, and very stat case during the appendix, and the ileocecal bar. So we'll label as right upper quadrant, left upper quadrant, and the appendix and the ileocecal bar. This is the scanning technique and how we provide a good scanning with the full information. Any questions so far? Okay, so we know now the anatomy, we know the normal appearance, and we get the information for healthy bowel. So it will be easy for us to recognize the abnormal. Once we know the normal, it's easy to recognize the abnormal. Once we know what is the checklist for a normal, anything it's not included, it will be abnormal. The common pathology that is very frequent and very common in our pediatric section: colitis or syphilitis, pyloric stenosis, appendicitis, and intussusception. They have a general checklist for abnormalities because it's all bowel. So it has the general information, we get it to say it's a disease or to say it's inflammation. What are they? First, the bowel thickness should be less than 4. If it is more, it's abnormal. That's it. 4.5, it's abnormal. As we can see here, if we measure it, as I showed before, from the bright line to the bright line, for here it's 1 centimeter, so this is abnormal. The echogenic wall appearance, as I said before, the normal appearance is a gut signature. We can differentiate between the 5 layers. When it is abnormal, all will be echogenic. As you can see here, it's all lies echogenic, no differentiation. We cannot see the 5th layer. It's become swelled and it's become echogenic. And this is one of the signs of abnormal inflamed bowel. Increased vascularity, any pathology in any ultrasound, we have to put vascular. We have to put Doppler. Is it hyperemic? It's lose the echogenicity. There is no echogenicity. It's part of our assessment. For any pathology, we are seeing it in ultrasound. This is when I put my color Doppler, I get very hyperemic, very increased echogenicity. One tip I want to tell you, do not lower your scale more than 5. Why? If we are lowering the scale, we'll get artifact, noise. So you have to be specific, not more than 7, and not less than 5. Less than 5 to reduce the artifact and noise, and more than 7 to be able to pick the inflammation. Okay,
so
this is
very... What is increased vascularity?
This is increased vascularity.
Please.
As you can see, it's inflamed bowel. The wall is echogenic and it's thick and it's hyperemic.
The upper, it's normal or increased all?
Which one? This one?
Yes.
This one, no, it's the bowel, it's the abdomen. This is the bowel only.
Okay.
This is only the bowel. This is just inflammatory reaction because the inflammatory bowel appearance. This is what? What is it here in the lower? Iliac.
Okay.
Iliac
This is
vessel.
okay.
Lymph node. While we are scanning, we have to look for what? Lymph node and free fluid. Once you see it, there is something wrong in the abdomen. Once you notice it, there is something wrong. There is a reaction. You have to look for it. If you are not seeing the bowel disease, you have to again rescan and see what's going on to have this lymph node and to see this free fluid. As you can see here, there is a free fluid between the bowel loop and this sub-centimeter lymph node. It's a reactive or reaction from the inflammation. The final thing is inflammatory surrounding fatty tissue. The body is produce fat when you have inflammation. This fat is the sign there is something wrong again in the bowel. So we are seeing the bowel. We measure the thickness. We put the color. We look for the lymph node, free fluid, fat surrounding. So our case is closed. We have inflammatory bowel disease. Once I collect this information, no radiologist will argue with you. You have all information to provide it to prove that you have inflammation, bowel disease. This is all the information you needed to collect. So let's go to the colitis. What is the colitis? Colitis refers to inflammation of an inner layer of the colon. It's implicated by several or numerous kinds of pathology, such as inflammatory bowel disease, ulcerative colitis, ischemic, and it's very frequent to our section because we are an oncology center, as we know. Most of the pediatric, after chemotherapy, after bone marrow transplant, they infected with the colitis, and they refer to us to rule out typhlitis or colitis. So it's very common and it's very frequent. As I say here, see your bowel, or sorry, this bowel infected, the echogenicity. So what is it here? Who can tell me? What's the sign here?
Increase the movement, peristalsis.
Yes, peristalsis movement very active.
Yes.
There is a fat surrounding it. There is a thickness. Is there any gut signature?
No.
No, it's totally different. Echogenic, thick layer. This is how it looks like, the colitis. Pyloric stenosis. It's a different examination. The patient will come to you to examine. Is it positive or it's negative? What is it? It's the thickness of the pyloric valve, and it will lead to what? Narrowing. The fluid or the content of the stomach cannot pass through to the bowel. So that it will be narrowing and it will be thickness. It's typically occurs between the first week to the 3 months ago of the patient. The patient comes with what? What is the main symptoms of
Projectile vomiting.
Projectile vomiting. What is projectile vomiting? When the vomiting is just shooting. The baby, when you feed it, it will shoot to you. Not a vomiting, it's going to leak through the mouth. It will shoot to you. This is the first sign that it has a pyloric stenosis. So most cases of pyloric stenosis, the only diagnosis is by ultrasound. There is no alternative modality. Ultrasound is the modality. You cannot ignore that. Once the doctor is suspect of ultrasound is the modality to rule it out or to rule it in. So it's easy ultrasound technique. Your window, it will be what? Liver and gallbladder. So you will put your baby on the bed. You will go to the what? Liver and gallbladder. Angle medially, go sagittal view. You will see your stomach, the stomach of the baby, and you will see the tunnel. Directly you will see the tunnel, as you can see here. This type of examination is divided into 2 parts. We will evaluate the tunnel first. We will see the thickness. We will see the normal measurement. See, this is the gallbladder and liver. This is your window, your sign mark. You'll see the stomach with content, and this is just the tunnel. Once you see it, when you evaluate it, you want to exclude all the information that we provided for abnormalities, and you want to include all information to see it's a normal bowel. And then what we will do, And then we'll feed the patient. You have to have a patient, this is the dynamic examination.
Give water.
The patient giving water to the patient, feeding tube. If he cannot feeding with a nasal tube, you have to have saline to inject while you are scanning. Why? Because I have this video to show. While you are scanning or feed your patient, this is, and you will put your probe just at the tunnel. You will see the passage of the content of the water into the small bowel. And this is, you can consider it as normal. This is a dynamic, nothing to document it. This is, you will see, you will observe it. But if there is a thickness, if there is an inflammation, it will be narrow. The passage of the content will not go through the duodenum. And you can see by observing and by documentation, there is a stenosis. So the water, it will not pass through, it will accumulate in the stomach. It's like squeezing the stomach back, providing what? Projectile vomiting. This is what's happening. This is what should include during your examination. Dynamic and taking images. Taking images that you have a normal, healthy tunnel with the thickness, with the length, and there is no vascularity, no free fluid, no lymph node, all the information, and then do the dynamic examination to see and to observe the passage of the water through the duodenum. Any question about this? I hope it's clear. It's an easy examination. We also do it in an ICU section because it's very frequent for a pediatric. You just need to observe and you notice, and it's easy to locate it once the stomach is filled with water.
Up to age?
3. Up to 3 months.
3.
The most common
From
was
the
3
first
weeks.
week?
The most common 3 weeks.
Yes. لما يكون ساعة في الاي سي يو في النيرسري هيلاقي هذه السيمبتوم. طبعا الفيدنج you have to have an assistant nurse or the mother of the baby to feed. She will start feeding and you will start scanning and observing. And you can sometimes we have an option to save as a video. If the doctor will not attend with you the exam. I hope it's clear. So this is when it is thickness by ultrasound. You can see here free fluid, thick bowel, echogenic, and there is some fat here, fat surrounding the tunnel, and the content cannot pass through. The stomach is extended and it cannot pass through. This is about the pyloric stenosis.
Measurement.
Measurement here. طبعا thickness it's a general less than 4 millimeter and the thickness 2.38.
يقيسوا منين لفين بس؟
الميجر as we can see from the bright line to the bright line. هذه الثيكنس حقتها. We cannot say نعمل measurement من هنا لهنا. This is the whole diameter. لا هذا هو الثيكنس فقط وهذا هو الدايمتر من الستومك لحد الدودن. اللينث.
تمام. الثيكنس up to
4
4
ملم. واللينث 2.3 سنتيمتر.
لا.
Okay. Appendicitis is the most on-call case. كل الأون-call عندك appendicitis. To rule out appendicitis. Patient هيجيكي with lower quadrant pain, with vomiting, nausea, عنده white blood cells high, على طول ultrasound. They will not refer pediatric to CT. They will not expose the patient to radiation. The ultrasound can be excluded and can be give them information. So you have to have a proper technique, proper examination. طبعا it's most حتى it can be happen to the adult, but it's most frequent to the pediatric up to 10 age and 30. How is the technique of the appendicitis? So first, my suggestion to you, look for what? Look for the ileocecal valve. As you can see here, this is the cecum, and this is the small bowel, and this is the opening. When you are locating it, go a little bit posterior and be gentle, because as I said, compressibility is one of the signs of a normal. Don't compress too much. You will find it, be gentle, just posterior to an ileocecal valve, then reduce your tip, you will see a healthy gut signature appearance, as you can see here. Follow it, follow it. Also, another landmark of appendicitis is what? Iliac vessels. Iliac vessels, it will be medial to the appendicitis. If you cannot cut it from an ileocecal valve, you can get it from what? An iliac vessel.
Easy, yeah.
And what's also blind end. Appendix has a blind end. It will stop. It will not continue. So you are in a correct position. You find your appendix, you evaluate it very well, you exclude all the information that we got it. No free fluid, no lymph node, thickness is good, there is no hyperemic, so you can prove that it's healthy or it is inflamed. And this is abnormal appendix, as we can see here. All information, the fat surrounding the gut signature appearance is disappeared, and if we can measurement, we will be see it more than 4 millimeter, and it is in the iliac fossa, medial to the iliac vessel. Now let's go to the interception. Interception, it's what? Interception when one loop of the bowel go inside the other loop. It's a very sad case. Very urgent case. You have to respond. The doctor has to respond. It can be transmitted. It's because of what? Because of a peristalsis movement. Sometimes there is no indication or there is no reason for exam to do it. It just happened because of a peristalsis movement. One loop comes inside other loop and it can infarct it. So it's very important to respond. It's very sad case. And as you can see here, it could be one of the loop, small loop go inside other, or large loop inside a small loop, which is very common اللي هو ileocolic interception when a distal ileum going into the cekium, which is the most common type it's happened for interception. As you can see here, this is the cecum, larger diameter, and this is the small intestine going inside. As I said, it's very urgent case. It's called ischemia and perforation, and it should be responded very quickly. So the only thing to recognize interception is what? By sign. I'm not looking for inflammation, because it's not inflammation. It's bowel go inside bowel, so I'm looking only for a sign. For a longitudinal, there is a sign, we call it high fork or a sandwich sign. This is it. As you can see, this is a 3-layer, 1, 2, 3, one going inside one. If I'm so the interception is very, very important to scan by curve, not only linear.
X-ray is diagnostic. X-ray,
yeah.
Double bubble sign.
Yeah, could be. As you can see here, also kidney. It's a sign when it is kidney, but it's not a kidney. You will not see it in the normal place of the kidney, which is in the loin. No, it will be in the midline, upper. So if you see it, this is an interception. Also, in axial view, we'll see eye-link, target sign. This is the sign. This is in the axial view, in the transfer view. Transfer and sagittal view. This is the sign of the interception. So we are not looking for any bowel inflammation. We are looking for a sign for interception bowel. As you can see here, they started with the curve, and then if we need more detail, we go with the linear for a superficial thing. This is eye appearance, and this is the donut appearance. And this is what? The high fork. Okay? So this is about the most common disease. It happened to the bowel. I hope it's clear. Any question?
For appendicitis, when we tell the surgeon there is appendicular mass and he interfere or operate the patient, and usually appendicular mass for observation, صح?
For me, if you see it by ultrasound, they need a CT to confirm it before they proceed for any advanced treatment option. If it's confirmed by CT, I don't know about the treatment. It's the surgeon or it's the doctor's decision. It could be observed. It could be going to the OR directly.
But the mass can be seen by ultrasound.
It can be
easily.
Yes, it can be seen. If it can be seen. This is,
Is there a chronic appendicitis? Chronic.
If we can see it, we will not see it. It's acute or chronic. It's inflamed.
Oh.
It's inflamed. You have to respond on that. Even if it is chronic, you have to react, either by medication or going directly to the OR. They will not wait.
مش عاوزة تسأل قول يا فندم.
تفضل.
بالنسبة للدايلة اللي ذكرتيه لا طبعا عرفتها.
Yes.
هل ناخذها على أساس اللارج باول ولا سمول باول ولا بس سمول؟
Both. Yes. لأنه الكولايتس يكون في الكولون والسمول باول الإيليوم. We can see it both. Yes, لأنه inflammation it can be in the small, it can be in the bowel. Once you see it, you have to document it. And what is the inflammation exactly? That's why we have 6 images, including the small and the large.
بالنسبة للتكنيك أو البوزيشن حق الطفل في الكرونيك في كونجنتال بايلوريك ستينوزس أحيانا بنعمل فحص والأم وهي شايلاه أحيانا هو يعني سوباين أحيانا الأفضل إيه؟
لأن this is, you know, ultrasound is a challenging, especially with the pediatric. Because
عاوزين خبرتك بقى في الحالات دي.
You are the one who getting the information. Sometimes I'm scanning while on the bed, me and the mother. The mother in the bed, the patient in the mother, and we'll scan. We try to get information, and you have to deal with it. The pediatric will not stay for you and be quiet for you. That's why it's a challenging. That's why we are sonographer. We are not technologists. I'm saying we are a sonographer. يعني we are the one. All thing is depending on us. The good information, the good quality, the most of the image is depend on us because I am the one who is scanning, not the doctor. The doctor will take the information I collect for it. If the patient is crying, try to modify it. Sometimes we're playing our music to calm him down. Sometimes we're watching our badges to calm him down, to put him in his mother, to be standing, to be sitting, to be lying down. Do whatever you could to get your information. There is no basic technique or there is no general thing I have to generalize it for you. Modify yourself to get your information. It's same as if you are scanning in ICU portable. The patient in bed, unconscious. You have to deal with it. You have to give us the information. Do whatever. Sometimes we're scanning from side and the machine from the other side. Just to get the information that we need. Just modify yourself, challenge yourself to get the examination done.
تمام. الباول فقط للإنفانت أو children ما ينفعش الأدلت خالص؟
الأدلت it will be a limitation. There is لأن the body habits is different. Now we'll have muscles, fat, gassy, belly tummy. All of this will make it difficult to evaluate. But if it's clear, the pathology, if it's clear. You cannot يعني ignore it. Especially adults, sometimes we just scan by curve, will not scan by linear. And it will penetration, you will not see anything because of the bowel and the muscle thickness. But if there is a mass, if there is any chronic disease, you will see it's inflamed bowel or it's abnormal. Free fluid, you can see it. If the adults and they are looking for inflammation and the patient cannot go CT because of contrast and renal failure, what you will do? You will get the maximum information you need. I will get, there is a lymph node, there is a free fluid, there is a fat. It could be suggested for syphilitis. I am not making sure, my case is not 100%, but I have some information. One of 3 of the information it's proved it's pathological.
Limitation للباول ultrasound في الانفانت يعني اللي يخليها difficult أو صعبة أو
Only the body habit and the patient if he's screaming he cannot come down. It can be solution if they cannot go for another technique by sedate the patient. Sometimes the patient cannot go for CT as I mentioned before because of the contrast and we have to scan the patient. And the patient is very loud, screaming, he cannot be still, we cannot provide, sedate him. We give the option, give him a sedation to do a proper technique. If the body habit, the pediatric, it's not the adult, we can. Even sometimes we need to compress. And they will facing you for compressing and will be screaming more while you are compressed. So you'll sedate him, distract him. This is the only solution. But in the pediatric, there is no big limitation by
The most common requested examination for bowel.
appendicitis. Appendicitis is the most common. زي ما قلت الانترسبشن it's common but not that frequent. لأنه sometimes it's just a transmit and we cannot catch it by ultrasound. They can just do fluoroscopy. Colitis, it's common when the patients في chemotherapy pediatric post manure transplant. Yeah, it's a common. It's يعني we can just rule it out easily even if it is general ultrasound abdomen and we can see it, we'll document it and we'll see it's a typhlitis of colitis. As I said, the bronchial stenosis, it's ICU procedures and not that frequent when outpatient come to us for projectile vomiting. Most of them are inpatients and ICU patients.
في محاضرة ثانية